Good afternoon, and welcome to the UCSF Academic Senate's first annual Faculty Research Lectureship in Social, Behavioral, and Health Policy Sciences. My name is Kartika Pallar, and I'm an associate professor in the Department of Medicine and chair for the UCSF Academic Senate Committee on Research. On behalf of the committee, it is my honor to introduce the Academic Senate Faculty Research Lecture. The Faculty Research Lecture Award in Social, Behavioral, and Health Policy Sciences was newly established in 2023, joining our existing Faculty Research Lecture Awards for Basic Science and for Clinical Science. As a member of the social behavioral research community at UCSF, I couldn't be more thrilled with this new opportunity to honor the impressive contributions of our social, behavioral, and health policy scientists. This prestigious award is bestowed on an individual member of the UCSF faculty with outstanding achievements in social, behavioral, and health policy sciences. UCSF faculty are asked to consider the outstanding research contributions of their colleagues and submit nominations for this award to the Academic Senate Committee on Research. For its inaugural year, we received numerous highly impressive nominations and had the difficult task of selecting just one individual for this award. I'd like to thank the committee for their hard work. Yeah. Thank you. Today, we are incredibly proud to honor our colleague, Dr. Diana Greene Foster. I am now pleased to introduce Professor Antonia Biggs, PhD. She is an associate professor and researcher in the Department of Obstetrics, Gynecology, and Reproductive Sciences, and senior researcher at Advancing New Standards in Reproductive Health, or ANSWER. Dr. Biggs is a nominator of Dr. Foster for this award and will now introduce Dr. Foster. Dr. Biggs.
Hi, everyone. Thank you all. So it is my great honor and privilege to introduce to you my friend and colleague, Dr. Diana Greene Foster. Dr. Diana Greene Foster has a PhD from Princeton, and we are incredibly fortunate, I think, to have her here at UCSF in the Department of OBGYN. So this is her professional photo, which is beautiful, but to give you an idea of her personality, I think this photo is so much better, right? This photo with her family, I think, does a much better job of representing who Diana is. It represents her empathy, nurturing, love, and generosity that's inherent in her spirit and in all of her work, including her interactions with colleagues. Dr. Foster is a passionate advocate of advancing science that informs policy to ensure women and other people with capacity of pregnancy can exercise their reproductive and bodily autonomy. This passion extends well past her rigorous science and into the holistic approach of her own life and the lives of those with whom she works. Dr. Foster understands that in order to do the important work of advancing science and creating a more just world, we must also nurture a healthy home life and create an equitable and fulfilling work environment. But don't mistake her incredible generosity of spirit for someone who lacks tenacity when it comes to science. Dr. Foster's dedication to boldly answering the tough research questions and employing the most rigorous research methods are forces to behold. Oh, and she is also a genius. And she's also really funny. A sense of humor is incredibly important to Diana, so much so that when she asked me to introduce her, she asked that I be either very funny or very short. So here is my short introduction of Diana Greene Foster. So I first met Diana when in 1998. When I joined UCSF, Dr. Foster and I both worked on the evaluation of California's Family Pack program. So of course I was looking for photos here to insert in the slide, but realized this was way before we had phones with cameras or even digital photos. So let's just imagine, here we are, a picture of Diana working in Sacramento, influencing the state's family planning policy. And here is where Diana posed the seemingly simple question that no one was asking. Why aren't we giving people a whole year's supply of contraceptive pills at once? Diana saw the incredible and obvious burden of making people come into a facility every single month, and she did not like it. But she didn't simply ask, she did it. She did something. Dr. Foster decided to take on the research that would change policy to allow people to get a full year supply of contraceptive pills at a time. And it worked. Her research directly changed California policy, policies that have now been also adopted in many other states across the country. Yeah. So now we can fast forward to 2007. Apple introduces its first iPhone with a camera. And this is when Dr. Foster again demonstrates her ability to take questions and turn them into robust scientific research, leading her to one of the greatest research challenges and achievements, and perhaps why we're all here today honoring her. It all began with Dr. Eleanor Dry, right here in front, medical director and abortion provider at the San Francisco General Women's Option Center, who asked, I wonder what happens to the people we turn away from abortion? A simple enough question, right? Well, it was that question that gave Dr. Foster the brilliant idea to take on the research and find out. Dr. Foster had the courage to implement an incredibly challenging study to answer the question well. Now, I used the word genius before, and genius can mean a lot of things, those with incredible aptitude, talent, or insight. But genius on its own is not worth very much without the strength of a person's ability to see the work through. And that, for me, is what sets Dr. Foster apart from the rest. So when faced with the task of rigorously answering this question, she set out to launch an ambitious prospective longitudinal study that overcame many of the extant comparison group limitations of prior studies. And this study examined the consequences of receiving or being denied a wanted abortion in the US. This study would require recruiting 1,000 women and interviewing them semi-annually for 5 years. And when you do the math, that comes out to nearly 11,000 interviews. Dr. Foster was undeterred. She knew that this task required assembling an incredible research team, including brilliant colleagues such as Project Director Rhonda Barrar, Heather Gould, Jasmine Powell, and countless others to achieve the seemingly impossible task of recruiting women who presented abortion clinics across the US at the moment of being denied an abortion, and then following them for 5 years. So think about that, having to recruit someone at that moment in time. No one thought Diana could do it, but she did. And in 2008, Diana began enrolling people here at UCSF, where she launched this immense task. This research has led to over 50 peer-reviewed publications and has now become widely known as the groundbreaking Turnaway Study and is considered the most rigorous and relevant research of its kind. But for Dr. Foster, peer-reviewed publications were not enough. She knew that in order for the work to have a real-world impact, she needed to prioritize translating and disseminating findings so that they would be used to inform policy, influence the national conversation, and create a culture shift. So, among other things, Dr. Foster wrote a book that has been translated to Korean and Portuguese and recommended on countless book lists. And so innovative and determined, in fact, was Dr. Foster to disseminate her research that not only did she write a book, but along with her sister, Leslie Greene, she turned her book about the consequences of abortion denial into a play. Can you imagine a play, a documentary play that is not only incredibly informative, heartfelt, and of course, extremely evidence-based, it's also very funny. So that, to me, is true genius. So the Turnaway Study now sits in the middle of the national conversation about what happens to the people in need of abortion who live in states that ban abortion. Last year, the findings made their way to House Representative Katie Porter's famous whiteboard, where she highlighted the study. The findings have been used in court cases across the US, also globally in Argentina, Honduras, and Chile, when considering expanding access to abortion. And Dr. Foster has been invited to speak nationally and internationally and has testified in front of the US Senate committees. She's been interviewed in a range of media outlets, including NPR's Fresh Air, New Yorker, Scientific American, just to name a few. And in 2022, Diana was featured by the scientific journal Nature as one of the top 10 most influential scientists, alongside an astronomer, a climate scientist, and an infectious disease physician who first discovered monkeypox. And this year, she was invited to give a TED Talk. And as if a book, a play, and a TED Talk weren't enough to mark the pinnacle of one's career, this fall, Dr. Foster got that phone call. The phone call, of course, was from the MacArthur Foundation, notifying her that she was awarded a 2023 MacArthur Fellowship, commonly known as a Genius Award. These Genius Awards are given to extraordinarily talented, creative individuals who have demonstrated exceptional promise. I cannot think of anyone more deserving. So now there's my evidence to support my case that Dr. Foster is a genius. And finally, while there is no question about the rigor and policy impact of her work, I believe another one of Dr. Foster's central achievements is that through her generous mentorship, she has cultivated new scientists and thinkers to carry out her vision. These Turnaway study investigators, all mentored by Diana, have grown their research portfolios, each studying their own innovative and cutting-edge topics. And as we all know, the state of reproductive rights in the US has changed. And while originally the study was designed primarily to assess whether abortion results in mental health harm, these findings are proving to be critical in demonstrating the detrimental impact of overturning Roe on all aspects of people's lives. And as the Turnaway study findings clearly demonstrate, people seeking abortion know their circumstances and can accurately foresee the dire consequences of not being able to get the abortions they want. And finally, among the many skills that I've highlighted today, Dr. Foster also stands out for her ability to give an excellent speech and to make us laugh, even when she's presenting on incredibly hard and challenging topics. So it is my pleasure to hand it off to Dr. Foster so that you all can see for yourself. So keep it short or make us laugh. Make us laugh. Thank you so much for watching.
Thank you so much, Antonia, Dr. Biggs. I just feel blown over by how nice that was. And I feel astounded by the reception of the things I've done, because none of them are the next step or being fueled by some outrage. Finding people who have skills I don't have, and you could say pushing, but I think maybe kindly suggesting that they, do something like give a funny talk, even if it's not necessarily what they usually do, and then having them completely shine. So that's my genius right there. It's really an honor to be here, to have UCSF. It's been Antonia and my academic home since we got our PhDs, which is a really, really long time ago. And to have a medical school acknowledge the social sciences that we're pursuing as important is just really amazing. It's, so to represent social science in this inaugural lectureship is really a big honor. I've made my whole career here, and I don't think I'm going to make a case for why it really couldn't have happened anywhere else. One is that there's just an incredible history of innovation around abortion and abortion clinical research in particular at UCSF. A long time ago, not me, other people at Answer made this beautiful timeline and history of abortion at UCSF, and it is long. I think it starts at 1850 or something. But UCSF has generated so much that's important around abortion care, from developing new procedures and technology, always with an effort to demedicalize abortion procedures, and to train the next generation of physicians to provide abortions, to elevate the science around abortion. All of this has happened as a base at UCSF. So I love that the first social science talk is also about abortion, because it's one of very few places that really does justice to a topic that is so important to so many people. Also participating in the trials of RU486 and much more that is not on this list, but always with a culture, UCSF in particular, culture of working towards the public good, and not just trying to perpetuate systems and technologies, but to really try and have our view on the potential patients and people who need care. I'm just excerpting one page from that historical PDF, which won a design prize. I picked the page that showed Jody as Dr. Jody Steinauer as a med student founding Med Students for Choice here at UCSF, to document the long history of abortion at UCSF. Clearly, abortion is a medical issue, and it's considered a stress test on every organ system, and changes the shape of your eyeballs and the bones in your feet, and every, pregnancy itself, while being pregnant, is is a major aggravator of all sorts of medical risk. But it's also, for pregnancies carried to term, the intrauterine conditions affect the health of the fetus for the rest of their lives. And maternal health is not just affected through the childbirth. It affects the health of the pregnant person forever, for the rest of their lives. And in a country with serious maternal mortality, this becomes even more pressing of a medical issue. But it's also a social science issue, because it's about sex and relationships and parenting. I had a lot of fun coming up with this list. Bodily autonomy. If I teach undergraduates, and if you were undergraduates, I'd make you shout out words that it also is about, but it's about racism and sexism and public policy and institutional policy and criminal justice. It affects our social debate, our politics, legal arguments. So we can't just let clinicians do this all on their own. So instead, we bring in demographers, sociologists, epidemiologists, public health researchers, psychologists. I'm not making you call them out, but there are some, and there are even more, to actually look at the context of this, to understand who can access and what the consequences are, whether they access or can't access, and how new technologies might increase access. And because social science isn't just someone sitting in a lab and looking at beakers, not that that's not super cool too, it involves a huge team of people. So you have to bring in these social science disciplines, and then a huge number of other researchers who can actually carry out this research, people with expertise in human subjects, in collecting data and recruiting for study and managing research teams. So all of a sudden, what is, seems like a small endeavor is a humongous team of people who all need to work together to understand at a greater level the issues of abortion. So I'm saying that abortion social science couldn't happen anywhere else, or at least not as well as it happens here. One is that we have a culture of working towards the public good, not in just, as I said, perpetuating standards of care that are outdated, or trying to maintain a cash flow from some health services, but to actually increase access and improve outcomes. And this at UCSF, embracing abortion as a serious subject for research, is, I think, one of our hallmark characteristics. And it, at the very beginning, when I started, Phil Darney sat me down and said, well, to advance here, you need to co-author papers. And I think that when you're at another type of department, a sociology department or a demography department, you single author papers, and it's not, the emphasis is not on that you should bring as many people as you can to participate with you in research. So, and it turns out that that's actually just fundamental to successful research, is bringing in a lot of people, getting a lot of perspectives. And a med school surprisingly opened my eyes about how research should be done, that it isn't just tacking people's names on, it is about getting multiple disciplines to all collaborate. And what we have here at UCSF is expertise that's wide-ranging and not superficial. So clinical expertise, research expertise, educational expertise at every level, the staff expertise that is required to run one of these studies. I'm making eye contact with Rana. I can't tell if she can see that. Is just critical to actually carrying out a study. And so we have expertise at the staff level, faculty, students, other academics, and then institutional support here, which, you know, UCSF is not an easy place because it's so huge. And yet there are these people at all corners who make things possible. I've recently discovered a whole group of people in data security. I'll tell you about that. If there was enough booze at the reception, I would tell you, but there isn't gonna be. So at the library, statistics consulting, the IRB staff, the amount of expertise you find in all corners of this university is just phenomenal. And last but not at all least, because there are excellent researchers in Texas who just closed up shop, California is a protected state. And so we don't worry about the governor turning in a budget that has all of our salaries, not that they're paid for by the state, but, you know, crossed out of the UC budget. So this is a really special place and time. And so much impactful and groundbreaking work is happening here. Not just clinical, but epidemiological data research on documenting the safety of abortion. I'm trying to make eye contact with people. How would they not be looking at me? Like Ushma Upadhyay, who was cited by the Supreme Court in demonstrating the safety of procedures and medications, identifying the best practices in evidence-based practices in abortion care that can streamline access. See if I can make eye contact with Dan. But I can make contact with a lot of people in this room. Good thing it's a small group. We're all going to get eye contact time. Ultrasounds, whether we need ultrasounds, whether there's required tests before an abortion, trying to get evidence-based, what is needed to have safe delivery of care, but that doesn't restrict access to care, and measurement of the harms of non-evidence-based policies. Carol, Katrina, and Dan are now doing a study on care post-Roe, of documenting how abortion restrictions actually affect other sorts of care, pregnancy-related care, impact of the bans on maternal health. Sarah Roberts is doing work on that. Lori on the impact of Catholic healthcare. There's a lot of advocacy here for evidence-based policy in terms of the FDA and in court cases. And then recognition of cultural impact. I love this. We're like real social science, that we're going to look not just at the moment of service delivery or the consequences after, but how does all of this impacted by the media, journalism, movies, TV. So it's truly awesome what's happening here at UCSF. So I know the other reason why it's a great honor to be doing this talk right now is that this has become a really important issue for our country. We know that we've just in the last year and a half experienced the end of a protected right to abortion at the federal level. Won't tell you about what the Dobbs decision was, but now, because of the repeal of Roe versus Wade, the Constitution doesn't protect abortion rights, and the right to abortion depends on where you live. And in 14 states, you can't get a legal abortion in your state for most reasons. that people would want to have an abortion. And this affects over a third of US women and an unknown number of pregnancy capable trans men and non-binary people. So a quarter of women live in states that have banned abortion, another 10% in places where it might be banned, and residents of these states obtained at least over 115,000 abortions in 2020. In 2020, there were bad laws in Texas, so that maybe they would have obtained even more had they not been subject to Texas's laws. And abortion hostile states, there were even more. So if doing work right now, we shouldn't give up, because there are a lot of states that could pass bans that haven't, and court cases that are holding it up, and maybe some evidence will help shape the trajectory of abortion rights in our country. So let's review the data, because in case you haven't been following, because it's really hard to keep current on this because things are changing so dramatically in this country. So I did my slides yesterday, I admit, and tried to update some of them, and they're probably outdated in some ways already. But what are the options for someone who lives in a state with an abortion ban? They can travel out of state to get a procedure. They can obtain medication abortion pills either in another state or through several other exciting ways that people in this group, in this room, and maybe on Zoom, I don't know who's on Zoom, have innovated. They can do what might be the saddest, which is to try and have an abortion in an unsafe way without medications and potentially harm themselves. And then they can carry the pregnancy to term. I'm going to tell you just a little about each of those. Okay, a lot about one of them. So they can travel out of state. Right now, more than a quarter of US women live more than 200 miles from an abortion facility. And we already know, because before Roe fell, abortion access was already bad enough that we could see that some people had very long travel distances, and this increased the cost of abortion, delayed people's procedures. And in fact, Kirsten Thompson led the analysis that showed that very likely reduce the chance that a long distance reduces the chance that someone's actually able to access care. And we know that there are some people who just will not be able to travel, people who don't have the money or resources, minors, undocumented immigrants, people who are institutionalized, either because they're incarcerated or hospitalized, people with disabilities. Dr. Ushmupadia is leading or co-leading the study that's looking at counts of people either traveling to get a procedure or getting abortions through kind of formal sector telemedicine. And I'm not going to make you read this table right away. I'm just going to point out the orange 2,200. This table of the counts of abortions in the formal sector that compared to the monthly average pre-Dobbs decision, that the monthly average in that next year, the total number of abortions in the United States went up. Isn't that shocking? And I'll grant you that the comparison months Texas had some restrictions in that were lowering that number, but still, it does seem like it's not what we predicted necessarily. I would never have put money on abortions going up in the year after Dobbs. The second option, you can try and obtain medication abortion pills. There's now just so many options for this that didn't exist even before the Dobbs decision. In 2021, a major change, the FDA, on the basis of evidence gathered at UCSF, Dan Grossman and Ushmupadia, try and make eye contact real quick, allowing patients to receive abortion pills by mail, where before you would have to receive it in person. And how can you get them? You can get them through telemedicine from states without bans. That was included in the WeCount data. You can get them through, I'm not sure if this is included or not, but telemedicine from Aid Access now sends it from within the United States. You can go to, there are online pharmacies where you can order pills with no medical advice at all, and someone will send you pills from an online pharmacy, often from abroad. And then there's Los Libres, a Mexican-based community group that sends pills as well. This was 10 months after Dobbs. The New York Times looked at all of these different options, and it showed that the cheaper the way of getting pills was, the slower it was. And at that point, the more expensive and least regulated arrived fastest. That's the online sellers. But we just had a talk from Francine Coito of Plan C Pills, and she says that this the dollar amount on online pill sellers has moved from 300 10 months ago to 18 months later. She said it's something less than $30 for ordering from an online pharmacy. So this is just a radical transformation in access to medication abortion pills. Going back to the 6 months after the Dobbs decision, this was a New York Times trying to quantify how many pills were sent. So just massive growth in sending pills online. And yet still this won't be for everybody. Not everybody knows about the option, and so outcomes and there's a hotline for that. And you could also have legal risk, and there's a different hotline for that. But the real concern is that fear of legal risk will prevent people from seeking medical care when they need it. So the threat of legal care, even if we can, of making abortion illegal, even if people are able to or circumvent their state laws, could be that people don't get follow-up care when they need it. And then here's a third option that Dr. Lauren Ralph led thank you for my eye contact pointers. Led to actually look at how often people try and induce an abortion without medications, without clinical help. And she estimated that pre-Dobbs, 7% of people women reported a lifetime history of trying to end their own pregnancy, a quarter of whom were successful. Some people using herbs, misoprostol and mifepristone, are likely very effective, taking large quantities of other drugs or alcohol. And then physical methods like hitting yourself in the abdomen or falling downstairs or inserting something in your cervix. And in her study, 1 in 10 needed treatment for complications. So this is like very possibly severe complications from this third option. And we know that, so from this, my summary of like all the dramatic changes in access to abortion in just the year and a half after Dobbs. We see that pills are able to be sent via mail, increase in the number of clinics, and increase in gestational limits in protected states, massive increase in telemedicine, massive increase in the volume of pills sent from online pharmacies and community groups, massive influx in money that supports travel. And so there is something of a concern that all this marshaling of resources means that people are able to access care, then will people be complacent and the resources will dry up? So that's a super interesting question that is not in my demographic discipline. I'll find someone who does have that expertise. But yeah, so I think that one thing is that all of these changes likely reduce unmet need in protected states, and we don't know whether that meets the base pre-Dobbs needs for people who are in states with bans. So legal barriers, fear of legal risk, who has access to information, stigma that might be increasing. People are very affected by what's legal in their sense of what's right, and will this law change affect what people think? So here's me not citing something that's UCSF so I can criticize it, because there was a new working paper that showed an actual increase in births in states, in banned states relative to states without bans. And yes, there's a relative increase, but in fact, birth rates have gone down in both of those sets of states. So we don't know. I think that it's certainly the case that we know from anecdotal evidence that some people cannot access abortion. And if that disproportionately happening in states with bans, I think it is. And is it probably the people with the absolute least resources, least information, least support, maybe worst health, that are the ones who can't access care? So here's the fourth option that I know a lot about. The fourth option, if you're in a banned state and you want an abortion, is to just carry that pregnancy to term. And it's from the Turnaway study that we can describe what the likely outcomes of that fourth option are. So what did we find? So I'm gonna try and shout out people who worked with me, because this faculty award, they gave it to one person, but they could have done a team award and we could have all been standing up here instead of me trying to make eye contact with you. And there are so many people whose expertise helped carry out this study. We recruited over 1,000 people over 3 years, people who were just a little bit too late to get their abortion, people who were just under the limit of their clinic and got their abortion. And because most of the sites had limits in the second trimester, but most people who get abortions do so in the first trimester, we also have a first trimester sample. And this study not just allowed us to look at the consequences of getting an abortion compared to not getting an abortion, but also was an amazing study for looking at later versus earlier abortion. And we've followed everyone for up to 5 years with telephone interviews and shouting out the people who are still at UCSF, but there were also, so this is Rana Barar, Jasmine Powell, and Heather Gould, who were fundamental to carrying out the study, but there were also a ton of people who then went on and went to med school or nursing school or policy school. So it was a launch pad for a lot of wonderful people. We recruited from 30 sites. Antonia Biggs led the papers on mental health in amazing journals, JAMA Psychiatry, if I could mention one. And here are just a few graphs. This is depression of people who received versus were denied abortions. No difference, and not because both groups were doing badly. In fact, both groups improved over time. No difference in suicidal ideation. A small difference at the beginning in anxiety, but over time, the two groups look similar. I'm not doing justice to these. I'm just showing off fun graphs. Felt high self-esteem, lower for people who are denied abortions, and eventually the same. And so really it was the mental health, why we did this study, why it needed to be done, because abortions were being restricted with the argument that abortion hurts women. And it was so important to document that in fact, there wasn't mental health harm from abortion. So we found more anxiety and lower self-esteem for people who were denied an abortion, but only in the short run. Over time, they converge, and so we've, in lay terms, denying a woman an abortion is more harmful than allowing her to get a wanted procedure. And all policies across the United States that tell people that say to clinicians that they have to counsel women about all the harms of abortion, those are not based in evidence. But just because abortion doesn't cause a mental health pathology doesn't mean that people don't have emotional reactions to them. So here are my colleagues, Corinne Rocca, who led a lot of the emotions, and Katrina Kimport, who hard to know where to put her picture because she could have been on so many, because she was like the high consultant when things got tricky on so many topics. But she did work on these papers too of emotional responses. So this is women who received an abortion 1 week later, their emotions. We asked about 6 emotions and categorized them as primarily positive, primarily negative, both positive and negative. That's the mixed in dark gray, and not having these emotions in low, or having low emotions. And what we see is, here's our most famous statistic: more than 95% of people who receive an abortion said it was the right decision, even among people who say they had some negative emotions, and even among people who specifically say they feel some regret. Because you can feel regretful that you're in the situation where you need an abortion and still feel like you made the right decision. And this is my favorite graph from the whole study. This is those same color-coded emotions over time. Positive emotions go down over time. Negative emotions start smaller and also go down over time. And what happens over time is that people say they stop thinking about it and stop having strong emotions. And one woman told us, the only time I think about my abortion is when you call us for these interviews. Here's the graph on it's the right decision over 5 years. And I stretched out the scale so you'd even be able to see the people who were more likely to say initially that it was not necessarily the right decision. And those are people who said kind of tautologically that it was a very difficult decision to make. So really people feel that they can make this decision and don't regret their decision later. We did ask people about who received an abortion, who didn't receive an abortion, whether they're glad that they were denied, which is weird because definitely there was a talking point for anti-abortion people that women regret their decisions. And no, I've never heard a pro-choice talking point that you'll regret it that you weren't denied. You know, this is not speaking to some political point, but it's felt good to have a parallel question. Some people say they are glad they had the abortion. The people who couldn't get it wish they had. And you can see that 1 week, 65% of the people denied abortion still wish they could have. By 6 months, they've given birth, and only 12% say they still wish they could have had an abortion, and decreased to 4% by 5 years. Dr. Gretchen Sisson's picture's there because she wrote a whole paper about adoption, and less than 1 in 10 women placed a child for adoption, but it's the people who placed a child for adoption who are more likely to say they still wish they could have had an abortion. And this is a tricky point. You know, people want to feel like their life turned out for the best. And I think that's what we are observing here in these data. And there are many ways that we can look at objective outcomes, whether their life would or wouldn't have been better off had they not gotten an abortion. And one of the biggest areas is in physical health. So epidemiologists Lauren Ralph and Caitlin Gertz on physical health outcomes, and the immediate health outcomes from the end of pregnancy show much greater health risk for people denied abortions, much greater chance of life-threatening complications for people who are denied, and much more serious conditions you see at the bottom. At the end, great effort, we got death data for everyone who was enrolled in the study and found 8 deaths, 4 among people who were denied abortions, and 2 of these were maternal deaths. So this is a shocking rate of death, 1 eclampsia and 1 infection death for people who are denied abortions. There were 4 deaths also in the second trimester, people who got second trimester abortions, but none were maternal. It happened years later. They were things like car accidents and heart attacks. So this study, one more, and then I will summarize with the sad death data too, but it's not just the end of pregnancy. It's not just maternal mortality. If we ask people about their health before the pregnancy and after, we see that women who are denied abortions are much more likely to report poor or fair health than women who receive abortions. Now look, I have quite a few physical health graphs because I'm in a medical school. Here's chronic conditions. The last one, we see higher gestational hypertension for people who are denied the abortion and carry the pregnancy to term. And it's not just this one pregnancy that they were forced to carry to term. Women in both groups ended up having many subsequent pregnancies. Chronic pain, all 3 of the top types of chronic pain, we are more common for people who are denied abortions than people who receive them. So to summarize all the physical health differences, women who are denied abortions have more gestational hypertension, a couple different types of chronic pain, and overall poor or fair health. No differences between people having first or second trimester abortions, and just a shocking rate of maternal mortality of almost 1% compared to less than 2 in 10,000 for the US generally. So other life outcomes, this is like all the rest of the study in maybe one slide, comparing women who receive an abortion, women who are denied an abortion are more likely to live below the federal poverty level, more likely to report that they can't afford basic living needs, more likely to be evicted, declare bankruptcy, have a lot of debt, less able to care for existing children, less likely to have an intended pregnancy over the next 5 years, They're equally likely to be in a romantic relationship with the man involved in the pregnancy, but less likely to be in a very good quality romantic relationship with any partner, and less likely to set aspirational plans. And a couple of those in graphs. Here's the chance of falling below the federal poverty by whether you got an abortion or gave birth. And I published that paper on in the American Journal of Public Health, and Sarah Miller, an economist at Michigan, reached out to me with the idea that we should link women in the study to their credit reports. In credit reports, you can get 3 years before they even became pregnant and 5 years after with no loss to follow up. And here you see that the two groups were exactly the same for 3 years before the pregnancy. At the year of the pregnancy, that's in between the dashed lines, they diverge and they don't converge again for the next 5. Economists love this paper, and they didn't like my self-reported paper nearly so much, but you should read it. It's like crazy what the language of economists. So that's part of the importance of accepting people from other disciplines to collaborate. Pregnancy, this is just another favorite graph of pregnancy intendedness between the child born because the mom was denied an abortion and the next child born to someone who was able to get one. And you see those subsequent pregnancies are much more likely to be intended. And it's crazy that it took to this slide to get to Sarah Roberts. Dr. Sarah Roberts did a ton of really cool papers on substance use, which I didn't present to you, but she also did this paper on violence and showed that when women are able to get a wanted abortion, they see a drop off in exposure of risk to violence from the man involved in the pregnancy. And if they don't get that abortion, there's no decrease. And Heather Gould did a bunch of really incredible open-ended interviews that are the source for stories in the book, the play. The quotes are everywhere, the stories are everywhere, they're so moving. She did those interviews, and this, my favorite quote from the study, is a woman in New York who was denied an abortion, who had to give the child to her mother to raise because she could not raise it due to substance use and domestic violence. But man, was she smart. We could have just had her give this quote for the entire study about how, you know, if you can't find a job when you're pregnant or keep a job when you're pregnant. And if you are so dependent on a partner, then that you are very vulnerable, especially if you can't trust him and he isn't supportive. And pregnancy is an incredibly scary thing if you cannot trust the person you're with. So I'm concluding the Turnaway study, but I'm not concluding this talk, so don't get up and go yet. So Turnaway study showed the importance of access to of abortion to women's physical health, the well-being of their families, and the trajectory of their lives. And we found big differences in physical health, financial security, aspirational plans, ability to take care of children. And really, what the Supreme Court should hear is that pregnant people can make decisions that are right for themselves and right for their families. And when we restrict their options, their lives become a lot harder. The top link is to our annotated bibliography with 50 amazing papers, and the bottom to the book. And so based on that study, do I think we're going to happen after the Dobbs decision is that wealthy people will still be able to get abortions, but at great cost and great delay. Lower income and otherwise disadvantaged people will be more likely to carry pregnancies to term. People who are pregnant and don't want to be will have serious physical health risks, and few people will place their children for adoption. And it's not like restricting access to abortion is a pro-birth attitude. In fact, more unwanted births now means fewer wanted births later. We quantify this, it is clear. And people who are unable to get an abortion will experience economic hardship and curtailed life ambitions, and more children will be raised in poverty and strain. And this will deepen existing health disparities and economic inequalities. So I'm trying to quantify, so those were my predictions. And if they come true, this is a team of people who will show it. This is the latest study, the End of Row study, which I'm leading with Dr. Nancy Berglass, with Elizabeth Gonzalez and amazing Jessica Barnes. directing to just try and recruit the last person in their state who was served before a ban came down, and the people who wanted an abortion after that and were turned away. And as well, people in banned states who call hotlines. We have who are trying to access care. We're working on trying to get some of the more people looking for mail order options. And just yesterday or today, there was a email sent out to all fetal diagnosis centers across America, trying to get them to help us recruit as well. But the question is, who is able to travel? Who self-manages? Who carries to term? You know, how much assistance is enough to keep people from trying to do something harmful or carrying an unwanted pregnancy to term, and looking at the legal, health, and economic consequences. So we have about 600 people from maybe 17 states. And this, I think, is my last slide on the social science at UCSF on abortion and beyond, and some of the values and things that we need moving forward. One is the value of collaboration, is that this social science, I think in particular, maybe clinical science also, just couldn't be done without colleagues who are other social sciences scientists, and this an actual culture that values collaboration has really strengthened our social science here at UCSF. Mentoring, for some reason, you don't get credit for mentoring people who are full professors, but as a full professor, I can say we still totally need mentoring. And when I was a student at Princeton, there was this woman, Cynthia Harper, who was already there, and she was 2 years ahead of me, and she knew everything, and she knew how everything worked. And then it turns out, like, she's here at UCSF, and I still, when a crisis happens, I haven't caught up. You'd think, like, we've both been here 25 years, the 2 years wouldn't make a difference. No, she still knows everything and how everything works. So we should get credit for mentoring full professors, because we still totally need it, and everyone should get Cynthia as their mentor. Funding, it's very hard to do social science at UCSF because there's no hard money. Unlike other traditional departments, this is super stressful. And as we are more successful, it's even harder because other types of researchers at UCSF can use pro fees and other sorts to cover over the cap, and we don't have that here. And so this is hard. And if we want social science to be sustainable and for people to feel like they have a long-term career here, it would be really great if there was more hard money and other support. And then it's totally gauche to ask for recognition while getting this amazing lectureship. But did you notice any pictures as we were going? There are a lot of people who are doing amazing work and opportunities for recognition in a university that is a medical school for people who are not physicians and nurses. We need more. Sometimes there are positions that aren't open to people who aren't clinicians. And given the contributions of social science at UCSF, it would be great if there was more of an openness towards recognizing everybody. I wanted one slide of thank yous. Look, our new chair is even here, Dr. Andrea Jackson, and other leadership that has made all the difference. Molly Battistelli and Dan Grossman at Answer, and Jody Steinauer, who's running Bixby, and my long-term boss, Rebecca Jackson of the San Francisco General Hospital Division. Thank you, because I think it really, except for Molly, they're all physicians, and yet the respect and open-mindedness towards social science makes a huge difference. And then totally not last, but thanks to all my colleagues at Answer and Bixby, and Antonia Biggs in particular, because that intro was so lovely. Thank you. And please contact me if you have any questions that you don't ask here. Thank you.
Don't leave yet. So before we move on to the comments and questions, we want to formally.
Made sure it was kick-proof while I was talking. It is. So much.
Thank you for that amazing presentation. And I imagine that you're accepting this award on behalf of many people. in the
I am.
community.
Yes. Thank you.
Yeah.
I'll just stay here forever.
So we have people on Zoom, and then of course, those of you who are in the room, we're open for questions and comments. And we actually have a nice amount of time.
I was feeling I couldn't quite keep track of the time and felt like I should rush. So I'll just do the whole thing again a little slower.
I'm going to start here in front.
First of all, my name is Lauren. I'm part of the second. Abortion funds and sort of, and I read your book, I think at some point. So just wondering, any comments on kind of where, what you see happening?
Yeah.
You know, I imagine that donations have gone up quite a bit. Do you think that that's, and do you think that people out there are?
That's such a great question, and it's part of like the massive transformation of abortion care in our country is they have grown tremendously, and I'm glad I didn't try and quantify it because it's rapidly changing. But I attribute some of the growth that Dr. Upadhyay showed in formal sector abortions is due to funds enabling people to travel, because traveling is expensive and the amount of travel that's happening is phenomenal. So I think abortion funds are having a huge impact, and because they're so successful, I worry about them, because what will happen when people learn that that people were able to get their abortions? Will they stop donating? So I don't know what's going to happen. And can Dan and Ushma be fast enough to get, to find other ways of people accessing care if they're not able to travel? When people who've donated to abortion funds hear that they've been so successful in enabling people to travel, and then they'll think, oh, the crisis is done. Look, people can travel, but it's only because they gave money that people could travel. So is that sustainable? And I don't know. It's so hard to be asked a question when I would like, well, what we should do is ask.
I see a hand at the back of the room.
Hi, Claire.
Diana, congratulations again.
In our end of row study, we are trying to keep it short, and we haven't tested the words policy climate for readability, but I'm guessing we're not asking about it exactly like that, but we are recruiting people who are living in states with abortion bans. And so they're definitely, and we're recruiting them from the sites they would have been able to access care if only the law hadn't changed. So it's like, they don't even have to know that the policy climate changed to have been hugely impacted by it. I have to think about your question. That was kind of a dodge, because I'm not sure that everybody knows that abortion is legal or illegal. And maybe that becomes less important as we move forward, whether people know and whether it's legal, given that there's different ways of accessing care now. Yeah, and that's not a new problem post-Dobbs. It's always been a problem that people don't necessarily know what the law is. And it's why it's so ridiculous when someone thinks, oh, now that abortion is less legal, people are going to use better methods of contraception. It assumes that people have any idea whether it's legal as they, go to bed. It's crazy.
we received a request to repeat questions before
Oh,
answering them for
shoot.
the folks on Zoom. Sorry,
Oh,
folks on
man.
Zoom. And Liz Greenwood is noting questions that are coming up in the Zoom chat. Liz, is there a question or two to share?
Yes, can you hear me?
Mm-hmm.
Yep, we do have a couple questions from the Zoom. And I apologize if these are repeats. Unfortunately, I wasn't able to hear the first questions either. But one of the questions is, how is the Turnaway study funded?
It was funded first through private foundations because at the time that we started, the NIH thought that the Hyde Amendment, which bans federal funding for abortion, applied to federal funding for abortion research. It has since changed its mind on that and is funding really amazing work by my colleagues. But initially it was funded by private foundations, including Hewlett and Packard, some through institutional grants and from anonymous foundations. And also Sarah Roberts got a NIAAA NIH grant to analyze the alcohol, the substance use data. So we did have some federal funding early on. But it's, yep, it's a struggle.
And then one more.
And the questions before where you heard the answers and not the questions, one was about the role of hotlines and another about whether people now understand the political climate in which they're seeking care.
Great. One more question from the Zoom. Someone says, thank you in all caps for having the courage to do this research. It has been so needed. I started doing research in this area, but was scared off. I thought that NIH research could just be ended if senators or congresspeople objected. And they want to know, have you had to contend with such assaults on your work? And do you still worry about it?
So I got one of the first NIH, great question, and I don't have to repeat it because, right? I got one of the first NIH grants to study abortion in Nepal. And it was a study, a Turnaway study in Nepal. It's ongoing. We're in year 5 of 5. And we wrote the proposal and it was called Consequences of Unintended Pregnancy in Nepal. And by the time it was funded, it was called Pregnancy, Context, and Health. So no abortion, no Nepal, not even unintended. And that's because they were worried that some Senate staffer would see the title and say, oh, that's frivolous, or oh, that's political. And it's just crazy, the idea that studying pregnancy and abortion is political, since it's so common. And in the absence of hard data, empirical evidence about the consequences of access to abortion, we make terrible policies based on ideology. So the importance of studying this rigorously is huge, and they have since gotten a lot better. And Dr. Ushmupadia just got one that I think has abortion in the title. That is shocking. So I think NIH that's the one of many things that has changed about the world post-Dobbs, is that abortion is seen as a legitimate topic of study. I would never have gotten the MacArthur Award, I think, if there weren't such attention to saying we should know much more about this than comes up in a political debate. And NIH heard it and is made an effort to put reviewers on panels who have some knowledge about abortion so that you get good reviews, and then actually be open to funding that work. It's a huge change. And you said, the person said they were scared off of doing this work. And that is, I think, why we have such a long history of doing that at UCSF, is because you couldn't be scared at UCSF of doing this work. A long time ago, I was recruited at a different university, and one woman who studied abortion there, she's the only one, was like kind of excited about it, and her colleagues were like, we already have one person, like, because, and you need more than one person. I don't blame her for trying to recruit colleagues. You need to have people to talk with and to discuss ideas, and to not have to know everything yourself, but to have colleagues. And that's why I'm so grateful for you all.
In the green.
It's first staged, it's had some readings. Oh, question, where can we see the play? It had some readings, which are fun, including one in Hartford, Connecticut that Loretta Ross attended. So I know, that's super exciting. And I totally want to tell the story about that, but I'll answer the question first. May 9th through 20th, it's playing in Ithaca, New York, at a theater that my sister happens to work with. So maybe that's why we got the in there, but there are leads in lots of places. But can I tell my Loretta Ross story? So Loretta Ross is this amazing reproductive she's one of the founders of the concept of reproductive justice, and she's an amazing writer and speaker. And I saw her name on the RSVP, the ticket list for this tiny theater in Hartford, Connecticut, and I thought, it could not be, no way she's coming. And there she was, and I was so like thrilled and excited. And we sat through the play, and there was a very young woman who said she learned a lot from the play. She's opposed to abortion. What she learned from the play is that people, when they're making a decision about abortion, are trying to do the best they can. And given that their outcomes are better if they get the abortion, the only solution is to not have sex unless you're trying to make a baby. And I, at that point, it was like after the play had read, and I was sitting at the front with my sister and the actors, and I like launched into I'm so glad you said that. I really feel like that's a valuable perspective, and that people can live their lives in different ways, and that's one way. And from the back, Loretta Ross shouts out, "Sexual pleasure is good." It was awesome. It was so awesome. Yeah.
In the house, yes.
One of you would sign my book. Two, I wrote it down. What would you say to so-called pro-lifers who make the claim of bias in your work? They point out data from the study, particularly that cared about the 96% of people who were denied abortion ended up saying they no longer mentioned it, and that these pro-lifers take issue with those findings, that they are rarely mentioned in dozens of articles about the study, are not mentioned on the website summarizing the study, and are not in the fact sheets that UCSF gives out.
Yeah. Yeah, I'm so glad you asked those questions. They do like that. Oh, I have to repeat that. Wow, that was a long question. I signed the book. That was pretty much all I heard. No, just kidding. She was calling attention to the fact that many people who get abortion, who are denied abortions, eventually say they're glad they were denied. And why isn't that statistic more widely cited or distributed? And then the objectivity of the study as a whole. Can I start in reverse order? Objectivity of the study as a whole. I made every effort to think about the ways in which I thought women who would have pregnancies carried to term would be better off. And we measured them. Ways in which there would be more social support, for example, life satisfaction, less stigma, and not just ways in which I thought people who got abortions would be better off, although we measured those too. And we didn't see things that I expected to see around life satisfaction. In fact, some people are happy that they were denied an abortion and had a child that they love. And that's, I think, why we see that 96% are glad that they didn't get the abortion. But people who did get the abortion often went on to have other intended kids later and got a lot of life satisfaction from that. And some people didn't want kids, and they got life satisfaction from other things that they pursued. And the fact that people were more likely to set aspirational plans and had a wider range of aspirations achieved if they got their abortion is part of, I think, what explains why there's life satisfaction in both groups, and that people who want abortions also want other things for their lives, and just not a child right then. And it doesn't keep them from having a child later. In fact, they're more likely to have an intended kid later. So I tried very hard to be objective in the questions we asked. We were very careful in how we asked the questions and how we trained people to ask the questions in objective ways. And at one point, one woman said she wouldn't answer the questions anymore unless we said we weren't trying to use this to ban abortion or to restrict access to abortion. So even the people participating in the study, some of them thought maybe with all the questions we were asking that we were somehow on a mission to make abortion look bad. So I don't think people participating in the study saw it as biased. We absolutely do promote, every talk I do that same slide about who's glad they didn't get an abortion and who's glad they did. And I think it's super interesting. And people are really eager to see their lives in a positive way. And people don't, when they're raising a child, feel like they wish they weren't raising that child, because it takes so much to raise a child that trying to do it with a feeling that you wish you weren't would be so hard. And I think people adjust and try and devote themselves to their kids. That said, we also have objective measures of maternal bonding, and it's worse for the people who are forced to give birth than the people who are able to get their abortions and have a child later. So people want to feel their life turned out for the best. And we certainly didn't tell them, yeah, but you would have better maternal bonding if only you'd been able to get your abortion, and your health would be better and you'd be a little bit less strapped for cash. And they're doing the best they can. And I think that is a valid reasonable response, and they don't know how their life would have turned out. They're trying to feel that their life turned out for the best. I don't know if that did it.
Right here.
Yes, we did. We did 2 sets of analyses. Oh, repeat the question. Rana still tells me what to do. And how long has it been since she's worked with me? The question is, have we done analyses of children's outcomes? There are 2 sets of children for whom we did analyses. One is the children women had at the time they were seeking an abortion. And we see that often people give their reason for abortion is to take care of the kids they already have. We can see that those kids do worse if their mom's denied an abortion. We see it in worse child achievement of developmental milestones, and in a greater likelihood that the child is being raised in a house without enough resources for basic living needs. And the other set of kids is the child born because the mom was denied the abortion, compared to the next child born to the woman who received an abortion. So this comparison is, what are the benefits or harms to kids if their mom is able to dictate the circumstances of a birth? And there again, we see economic differences in the chance the kid is being raised in a household below the federal poverty level, for example. Also differences in maternal bonding. So this is a validated British scale that asks about maternal bonding, and at extreme levels is predictive of is called poor maternal bonding. That scale, it's not that everyone who has a baby when they preferred to have an abortion has poor maternal bonding. That's not the case at all. It's something like 8% of people who are denied an abortion, compared to just under 4% for people who receive an abortion and later carry to term have poor maternal bonding. So there's nothing that says your outcomes are going to be terrible. It just, on every measure where there are differences, we can see that things are just a little harder for people who can't get a wanted abortion. And there's a whole range of experiences. And yet, on average, people who are unable to dictate the timing of their births have a harder time.
We have another Zoom question. If that's a
Hold on just 1 second, Liz. There's back and forth happening.
I don't think we're doing that for kids. Dr. Lauren Ralph is doing, looking at educational result, long-term education for the pregnant person, but I don't think we're doing it for the kids. Oh, I didn't ask the question, say the question. She asked whether we were gonna do long-term outcomes for educational outcomes for kids.
Okay, thank you. And Liz, did you want to turn to the Zoom question?
Great. The question is, do you share the results of your research with the study subjects? This is such an incredible amount of valuable research for many different reasons. I wonder how people react to seeing the aggregate results.
We offered it to everybody, and we shared a website if people said they were interested. Oh, I didn't have to repeat the question. Yeah, so we were open to it and we offered it, but I haven't gotten. We got lovely thank you cards from some people who at the end of the study sent us a thank you card, which blows my mind. Okay, it was just one person, but isn't that lovely? But I think most people didn't understand. They didn't know there was a comparison group to their experience. They were doing regular health studies. The study wasn't called the abortion is good or bad study. It was it had a health related name, and people thought, and we stopped asking. We rarely asked even about that pregnancy. So over time, people could have even forgot what the study was about. It was about their health, their life plans, their economic well-being. And I think they would at the end might have been surprised that it was abortion related.
I see two hands here. I want to make sure that we both get a chance.
Yes. Oh, whoops. The question was whether, given the legal climate, whether for our new study on the consequences of the end of Roe, whether people participating would worry about their getting in legal trouble if the data are subpoenaed, if somehow their phone is the data, their confidentiality. Yeah, we're concerned about it. And it's another area where UCSF has been very good, is advising us on how to protect our data and saying that they will stand behind us in the case of subpoenas.
Yes.
Thanks so much for all your great work. So, probably now that how are people working on it? How is that, or how is safe and accessible?
So the question was, now, how are people finding out about medication abortion, and are people concerned about legal risk if they order it? Is that paraphrased enough? I don't know. I am so amazed at the dissemination of information and how wide the growth in travel, the growth in pills ordered online. I am just astounded at the speed of word of mouth. This wasn't public health departments in Alabama with billboards about, how to find information. So it is happening outside of a public health framework, and it is truly astounding, the dissemination of information. And Latin America shows us too that information can disseminate through grassroots groups, even when it's illegal and even when it's political. and I didn't even know how to, there are other people who would do better on that question. Call people up. Yeah, it's astounding, and good thing there's a reception. So everyone look and see who asked the question and answer it to her.
We have time for a couple more. Oh, yes.
One or two questions. One, providers and difficulty in decision making of like, do I provide this care or do I save this woman's life or not?
Yeah.
It's like, and then, yeah, just I'm curious about how much you're studying. This is the one we just saw in Texas where yeah, you're thinking about following how much your current study is like more.
Okay. But paraphrasing is even harder than answering. The first part was about studies of providers, and there are amazing people in this audience who are doing studies of providers. Lori Friedman in a hospital in Indiana, Dan Grossman on people trying to care for people who are pregnant in banned states. Who else was I going to call out? Jody on training people. How do people get trained when? So anyway, so everyone look and see who asked that question for the reception. And now what was the other part? Longitudinal, we are following people for 2 years. The Turnaway study was good in that we don't have to follow people for 5. Once we establish that someone's on the track of giving birth, we can look at the first 2 years and say, well, is that the same track that the people we already studied for 5 years are on? So we are only following for people 2 years. And I think that the real questions are going to be answered very quickly in who's able to access care, were there legal consequences, how much did people have to pay, and how much did it slow them down to not be able to get an abortion in their state legally. So a lot of, we're following for 2 years, but the most critical stuff is happening at the beginning. Did that?
So we have a couple last questions on Zoom, and then I think we'll be wrapping up, but there is a reception after, so for people to continue these.
To ask their questions to the people who know the answers.
Liz, you want to
Yeah,
ask the Zoom questions?
great. I'll go down. We have 4 more questions, but if we hit 5 p.m., we can do as many as we can. So such important work. Thanks to you and your teams. In addition to educating policymakers, are you studying effects of your work on the education of our future care providers, such as curricula, practice choices, patient education materials, et cetera?
Since it's almost 5, do you want to do them all? And then I can answer the one that I have the best answer for.
Cool. 70
No was the answer to the first one. I'm not studying that, but it's awesome. And someone should study it.
Cool.
How it's being used.
Did you ever have a chance to ask women who are denied abortion if they thought that having the baby messed up any part of their lives? So like they mean asking for their perspectives on how being denied an abortion affected their lives.
I don't think so. I don't think we asked that. I have to think about it. Sorry. Oh, yes, we did. Oh, thank you. I was trying to think of like quantitative questions. Yes, we did. We absolutely asked exactly that question in the qualitative interviews. We asked, Heather asked about how they feel that getting an abortion or not getting an abortion changed the trajectory of their lives. Whew, that was not a quantitative question, but yes, we asked it in qualitative questions because it's not a quantitative answer. It's about someone reflecting on their life. And so read the book because it's got people telling, I mean, I should show you the ones that didn't make the book, which are as good as, can I do, oh, I should. when I was wanting to do qualitative interviews, I wanted to handpick just the juiciest, like people who in response to open-ended questions gave the juiciest answers. I wanted to handpick those people to do open-ended, and Katrina Gimbort said, no, that's not how social qualitative work is done. Why don't you start with a random sample and see what you get? And the people in the book were actually randomly selected with a few exceptions. And so people just really are that interesting and have amazing things to say about their lives.
Great.
Sorry, back to you, Liz.
Yeah, any studies asking questions of the partners of those who were turned away?
That's a good one, and I get that. And there should be studies of the partners, and we didn't do it. I didn't do it, and that's in part because it's really hard to, if I recruited from the people who were accompanied their partner to an abortion, that wouldn't be a representative sample of partners. But it's such an important topic. Maybe I should have, because even getting their perspective would be interesting. We wanted to leave there room for the next generation of scholars.
Last Zoom question. In the time of Dobbs, would it be preferable to use the term forced childbearing instead of abortion denied?
I don't know. That's not my expertise either. I don't know. Political speech is hard. I don't know about the wisdom I'm not trying to, I think abortion denial was accurate for this study, and I don't know what the effect of a term like that is in terms of achieving a political aim, or is it closer representing? It is people's experience. I don't know, but that is a good topic for the reception.
Great.
Everything is getting deferred to the reception. You guys thought it was gonna be a relaxing reception. We got work to do.
Well, thank you everybody for attending this wonderful event, everyone on Zoom. We're sorry that our attendees on Zoom can't join us in the reception to continue the discussion, but please, everybody, stay and talk.